Good day everyone. Today, I'll be talking about Addison disease, or also known as primary adrenal insufficiency. So, Addison disease is a rare but serious endocrine disorder that happens when the adrenal glands located just above the kidneys are unable to produce enough of two vital hormones, namely cortisol and aldosterone. The term primary means that the problems start inside the adrenal gland itself, not in the brain or the pituitary gland. This condition can develop slowly over time or suddenly as a life-threatening adrenal crisis.
To put this condition into perspective, let's look at the numbers. Addison's disease, or primary adrenal insufficiency, or we can say PAI, is a rare disease. Its prevalence is very low, affecting only about 100 to 300 people per million. We can only see about 4 to 6 cases annually per million people worldwide. Despite its rarity, the risk of a life-threatening adrenal crisis remains a major challenge. The incidence is alarmingly high, with reports showing 4 to 17 crises per 100 patients each year. Looking at the demographics, there's a clear disparity. 76.6% of patients are female, while 23.4% are male. Finally, to note the geographical context, while the disease is typically an autoimmune in richer countries, tuberculosis remains a prominent cause of PAI globally. The data for rare diseases are often scarce, and as an example, our slides show the difficulty in gathering centralized data here in the Philippines. At the core of Addison's disease is an autoimmune attack that unfolds through these cellular steps. Autoimmune priming. First, in genetically susceptible individuals, the immune system loses its tolerance and develops autoantibodies, specifically against the 21-hydroxylase enzyme, and these markers appear before the symptoms begin. Next is the T-cell mediated cortical injury. Autoreactive T-cells infiltrate the adrenal cortex, and they release local inflammatory cytokines, leading to apoptosis, or programmed death of the hormone-producing steroidogenic cells. Loss of steroidogenic machinery. This destruction eliminates the adrenal cortex's machinery and disrupting critical steps in the mitochondria and smooth endoplasmic reticulum, causing the collapse of cortisol and aldosterone synthesis. Mineralocorticoid signaling failure. The lack of aldosterone means its receptor-dependent function is in kidney fails. This results in the loss of water, causing hypovolemia and hyponatremia at the cellular level, which leads to potassium retention or hyperkalemia. Next is endocrine feedback and crisis physiology. Finally, the consistently low cortisol levels remove the negative feedback on the brain's HPA axis. The pituitary gland overcompensates by surging ACTH. This excess ACTH includes a component called MSH, which stimulates pigment cells, explaining the characteristic hyperpigmentation. The result of these deficiencies is stress intolerance. The ultimate result of these deficiencies is stress intolerance, making the body vulnerable to an adrenal crisis.
So now, we will talk about the endocrine cause of the disease. The endocrine cause of Addison disease is the destruction or dysfunction of the adrenal cortex, which is the outer layer of the adrenal gland responsible for making steroid hormones. In most cases, this damage is caused by an autoimmune reaction where the body's own immune system mistakenly attacks the adrenal gland cells. Antibodies such as anti-21-hydroxylase destroys the tissues that makes cortisol and aldosterone. Other causes include tuberculosis infection, adrenal hemorrhage, HIV or fungal infections, or metastatic cancer spreading to the adrenals. As a result of this destruction, the adrenal cortex can no longer produce sufficient cortisol and aldosterone. This triggers the pituitary gland to release more ACTH in an attempt to stimulate the adrenals. But because the glands are damaged, the hormone levels remain low, leading to the symptoms of Addison diseases. The impact of Addison disease on the body is widespread because cortisol and aldosterone are essential for survival. When cortisol levels are low, the body struggles to respond to stress, leading to fatigue, weakness, low blood pressures, and low blood sugar. Cortisol also helps maintain vascular tone, so its absence continues to dizziness, fainting, and a poor stress response. When aldosterone levels drop, the kidneys cannot retain enough sodium or water. This can cause salt craving, dehydration, and severe drop in blood pressure. Because the pituitary gland continues releasing high levels of ACTH, patients often develop hyperpigmentation, darkening of the skin, especially in the creases, scars, and gums. Overall, the loss of these hormones affect multiple organ systems, the cardiovascular, renal, and nervous system, making patients extremely vulnerable to stress and infection.
Addison's disease develops in a few distinct ways, but the most common form, autoimmune Addison's, is a slow and silent process. Gradual loss. The adrenal glands are slowly destroyed, often over the years. This process is so quiet that the disease progresses unnoticed until nearly all of the gland's function is exhausted. When a small amount of remaining functional tissue is gone, symptoms finally emerge. This explains why a stressful event like an infection often unmasks the disease, leading to a crisis. Next is the ACTH surge or hyperpigmentation. As cortisol production falls, it lifts the brake on the pituitary gland in the brain. The pituitary responds by massively increasing the output of its stimulating hormone, ACTH, and high ACTH levels also drive a related hormone called alpha MSH, which is what causes the characteristic hyperpigmentation. Next is infectious causes. While autoimmunity is most common in rich countries, this disease can also develop quickly or slowly due to infections. Causes are sometimes abrupt, such as severe hemorrhage or sepsis that can damage the glands, or it could be chronic like tuberculosis, or certain fungal infections slowly infiltrate and destroy the adrenal tissue.
Now, let's look at the metabolic impact. Cortisol is a glucocorticoid, which means it regulates glucose metabolism. It helps the liver make glucose from amino acid and fatty acid through a process called gluconeogenesis. When cortisol is deficient, this process slows down, leading to low blood sugar or hypoglycemia, especially during fasting or illness. Without cortisol, protein and fat metabolism also become disrupted, causing muscle weakness, weight loss, and fatigue. Meanwhile, the lack of aldosterone causes the body to lose sodium and retain potassium, resulting in hyponatremia or low sodium, and hyperkalemia, which is high potassium, and metabolic acidosis. These imbalances further worsen weakness, confusion, and dehydration. In severe cases, especially under physical stress, these metabolic changes can lead to an Addisonian crisis, characterized by extremely low blood pressure, shock, and even death if untreated. The treatment for Addison's disease is a straightforward principle. It's about replacing what's missing and preventing a crisis. So an example of this is chronic replacement therapy. So Addison's disease patients take oral steroids daily, and this involves two types of medication: hydrocortisone to replace the missing cortisol, and fludrocortisone to replace the missing aldosterone. So doses are carefully adjusted or tilted by monitoring symptoms, blood pressure, or electrolytes. Next is stress dosing and prevention. Since the adrenal glands can produce extra cortisol during times of need, patients must be educated on sick day rules. If they have an illness, injury, or surgery, they must increase their glucocorticoid dose. They must also always carry an emergency injectable hydrocortisone kit and wear a medical alert ID to inform first responders. Next is the adrenal crisis treatment. If the patient is in a life-threatening crisis, the treatment is immediate and aggressive, often done in the ER or ICU. So it includes a large immediate dose of IV hydrocortisone, typically 100 mg, aggressive resuscitation with saline fluid to restore blood volume. Aggressive resuscitation with saline fluid to restore blood volume, correcting imbalances like low blood sugar, which is glucose, and high potassium. Finally, treating the underlying trigger, such as a severe infection. So that is it for our presentation. Thank you so much for listening.